Okay, we are back here again. Hello, everyone. Okay, so as I was saying, um, oh, Tanvi cannot join in. um, yeah, as I was saying, that yeah, the bowel for the bowel movements. No, sorry, I'm having like everyone. Two of them are still trying to join in again. Yeah, so let me just try that once. Sorry about that. Okay, so just I think everyone should be here now already. I hope. Yeah. So any more questions, please?
Hi, Sumana, Gauri here. I just wanted to ask if the patient says that he is too fatigued, and then should we still go ahead with the assessment, or because he is too fatigued, then can we not do? Like, what is it?
They might act like that. Sometimes some are like instructed to be very uncooperative. I got that kind of client, very uncooperative, crying and telling I'm too tired. So you have to then convince them. They want to see how do you are you able to build a rapport. So give them options. Would you like to lie down and talk with me? Would you like me to bring the bed up a little bit? Would you like me to place a pillow under your knee? Sometimes that may relieve because it's a bit more comfortable position. Or ask them, is it the pain? Do you want me to give you medication? But like you can't really stop. You can maybe if that happens during the objective assessment. Let's say you are doing some objective assessment. They say like I'm too tired. Then let them take a break. Let them like maybe go back and lie back down, or take that opportunity when they lie back down or that rest point, take it as an opportunity to educate the client, keep talking about why you are going to do this treatment or what you have found so far. So they really don't like silence or awkward stop in between. So use every gap in between. Like what I did was, my client was so upset, and so what I did was, I whenever he was like I needed to stop, I would let him stop, but then I would say, like, while you're resting, let me tell you about what's really what is angina, like why you let me tell you a bit about it. So I kept using it as my patient education point.
That's right.
That saves your time later on as well, and then that helps to build a rapport. Yeah. Okay. Now, if there are not any more questions, how about we discuss like short term and long term goal, and you could tell me. Oh, any one of you can tell me what would be what are the possible short term goals from the subjective assessment that you could find? Because short term goals usually, yes, you have to please remember, goals has to be client centered. You have to ask them. So the sentence to use would be, what do you expect from me today? What would you like to be able to do today? And sometimes they will tell you very strange things, or sometimes they will be like, I don't know, I'm fine, I just want to rest, go away. So then you can, and then you have to start negotiating, then looking at your subjective assessment, bring out points from there and say, look, I noticed this is happening, would you like to work on that? I can really help you with that. Again, the same thing with long-term goal, asking you what do you expect to be able to do in a few months from now, like making it clear that it's not something you can do today, and that you use the information from pre-morbid mobility level and the hobbies or the work, because that already is so easy to set that goal. Like if they say, yeah, I was able to do football, then you can say, do you want me to, let's set that as a long-term goal. Maybe in 3 month time you can work towards that. Yeah. So what about the short-term goals? What do you think are the short-term goal uh, assessment points that you can use as short-term goals? Anyone, please?
So one can be cough if the patient is not able to cough. We can bring out sputum. If patient is unable to bring out sputum, we can teach them ACBT. Then if patient has pain, if it's a surgery case, then splinting is another thing.
Yeah, perfect.
And then if a surgical patient and has not been mobilized, which we will know in the subjective assessment when we will ask if the patient has walked since the surgery. So mobilization can be another.
Yeah. Yeah, but then again, when you said that, just make sure to set a distance as well right away. Like just say, if you haven't even got out of bed, we could try to get out of bed today, walk around the bed, like keep it like easy goals for yourself and for the client. And you can change in between. Like he says he gets up, walks on very easy, then say, do you think you would like to walk a bit more further? If he says yes, then we can go ahead. But then always need to ask. Anaz is saying that she cannot hear my voice. Are you able to hear now? I hope you can. Anaz, are you there? You are still on mute.
Maybe she has a problem because all of us can hear you.
Yeah.
So I think she can leave and come back again.
You mind? Yeah. Yes. Anaz, can you hear me? Now, maybe if you could leave and rejoin again, please. Okay. So can anyone else think of other goals from the subjective? So pain, we have got walking distance, anything more?
Yeah, actually, I think short-term goals should be set according to the problem list that we have during the subjective assessment. For example, we can add if the patient need to be educated. This would be one of my goals, not his goals, to educate it for things like normal pattern of breathing. If they have a bad pattern of breathing, or abnormal pattern of breathing, if they are using the accessory muscles of respiration, for example, I teach them splinting and breathing control to control their breathing. This would be my goal.
Yes, that could be one. Breathlessness is a right away short-term goal. So breathlessness, I would say, if you notice there's breathlessness and he's telling you that, then that should be a first goal to deal with. If someone has breathlessness and walking as a goal and clearance of airway clearance, then please prioritize breathlessness first, because if you can get the patient comfortable and breathing better, that's when you can walk the person, or you can get him out of bed, or you can, help in airway clearance. So always please prioritize breathlessness as soon as you see that. The other thing could be...
I just had a doubt. If the breathlessness is one of the priorities and we want to treat that, would it be, what would we do? Like, would that be the relaxed breathing, or what we would exactly do for breathlessness? Or we would just use the puffer? What would be that?
Oh, you could use puffer, or yes, you could use puffer. Yes, if the person is getting very breathless, then use the puffer, and then, or you can, I will talk about it in the treatment section as I go through, but we can do all these techniques as well. Yeah. Okay. So, and long-term goals could be, as I said, like any activities, or if the person is retired, then any ADL activities that they really wanted to do that they have not.
Samana? Yes. Sorry, can you just give a brief of short-term goals, because I didn't have your voice then?
Oh, right. So short-term...
Thank you.
That's all right. Short-term goals could be any goal that you're able to achieve in the session itself, today itself, right, within that time. So we discussed about possibility of using breathlessness. If you see breathlessness in the client, and then please do prioritize doing breathlessness first. Make the client comfortable first, then only do airway clearance. What happened with one of the candidate I had was like, he did both. He did breathlessness as well as managing breathlessness as well as airway clearance. But the mistake he did was he first tried to clear the secretion, worked on ACBT first, and then later he gave like techniques like pursed lip breathing and forward leaning. So he didn't didn't pass, because they look at how you logically plan your treatment as well. So breathlessness management is always first, fatigue management after that, because that is about the safety of the client. Pain management, of course, at the beginning itself, you have started with pain management. Then look at other things like airway clearance. Do you need, like, if he has cough, then how to manage your cough, how to bring out sputum better. Then in walking distance, or getting out of bed if he hasn't got out of bed, or it could be basically around these things, or pain during cough, so managing pain during cough, or someone with very bad breathing sounds, or someone who says that, I cannot do a deep breath, then working on a lung expansion techniques or treatment options around that. So that would be short term, because you can show improvement right away in these things. And then long term would be, as I said, activities or work related goals. Then next we have, I'm sorry about this mark here. I have really no idea what's that mark. We'll ignore that. Okay, so objective assessment, as we go through, I like to go head to toe with my observation. So first of all, it's always observation. You have already started with your observation in the beginning of the subjective itself, because you have looked at whether the oxygen level is right or not. You have, but then now when you start the objective, before you do, again, please remember to take consent. They do watch out for that consent every time. So say, now I'm going to start my objective. I will need to touch you and I need to examine. So is that okay if I go ahead with that? Yes. Then you start with head to toe. So here, head to toe, let's look at this client. What do you see right away? Anyone, please?
Yeah, shoulders elevated.
Yes, that's a sign.
Hyperinflation.
Mm-hmm. How did you see that? What was?
The chest shape is hyperinflated, like in the middle of the chest is expanded.
Yep.
The ribs are prominent.
Yep.
And the accessory muscles of respiration are tight. We can see his shoulders elevated and neck is tight, scalenii muscles.
The patient is using the oxygen via nasal prongs.
Yes, that's good one to read. Always please remember the external attachments. Yes.
Patient looks malnourished.
Yes, that's also one good point. Yes. So that now you can note that, so you can then talk about how about his appetite. You would have asked that in the subjective as well, or you can ask it anytime if you have missed on it. Then you can say, would you like me to refer you to a dietitian or talk to the nurse about this? Yeah. What about his lips? I see a little bit of pursed lips there. It seems like he's doing pursed lip breathing, because he has, pursed kind of lip, and he looks like he's blowing out from there. So I would observe that. This thing here, this intercostal indrawing, is also called a Hoover sign, and that tells me that his diaphragm is really lowered. Diaphragm because of the hyperinflation of the lungs, and then when he breathes in, the diaphragm pulls inward, and then you see the intercostal indrawing here. I would notice for other things, but I don't see particularly. There seems to be something here. So also in the exam, like that, if there are tapes or anything, please do ask. Like if you see anything, please ask. Like, oh, I see there is something. What is it? If you're not sure, you can ask like, what is it? Because sometimes they have like attached. In some scenarios, what they have done is they have attached a tape, and then they're not really connected at times. Then you need to ask like what that is, and then they would tell, oh, this is a IV line. Oh, it's just not connected over there, but it is there, or something like that could happen. Just be careful with anything on the body that you see, any attachment, any tapes or anything. So first of all, external attachment. Looking for IV line, as I said, oxygen cannula or mask, pulse oximeter, BP cuffs, anything around there, what's attached there, look for that. Indwelling catheter, usually the catheter will be coming out of his trouser. In this simulation exam, it's just attached to a trouser and then it's connected to a urine bag. PCA, for the PCA, there will be an additional black switch kept next to the client or on the bedside table, but then that's connected to a syringe pump. Then you know right away it's a PCA, patient control analgesics. You will expect to see this after post-op cases, so prepare to see a PCA. It's also stated on the file. If you want to prepare yourself beforehand, it's always written there in the file. Epidural line is something that most of the time we may miss because it's at the back. And usually it would be there for thoracic surgery cases or even with someone with intercostal drainage. I have missed to put that point here, sorry. So intercostal drainage or intercostal catheter would be there, a big pipe coming out from the side of the chest. And so note all of these. And epidural would be a thin white pipe at the back, and there's nothing there really, just a thin white pipe is connected with a tape onto the back because it's all simulation. It's quite you have to just remember that how things look and then look for it around the patient. Then you always start with taking the vitals, SpO2, heart rate, blood pressure, respiratory rate. So if it's not connected, that vitals monitoring system, you would have to bring around the patient and connect it. One thing to remember with vitals monitoring, please, when you put the BP cuff, do not put it on the same arm where you have IV line, because that when you put the cuff on, it can cause discomfort to the IV point, and that's not again safety for the client. So remember to put it on the other side and check the BP. You just need to press the green button and and after some time ask for what's the heart rate, what's the respiratory rate, what's the blood pressure, what's the SpO2. They will give you, the examiners will give you the prompt. Most of the time for SpO2, they will just say, oh, it's what there is, or they may say, oh, it's lowered, it's at this percentage. Then you could do the respiratory rate if you feel it's important. Mostly, it can be avoided as well. If in all these things you forget the respiratory rate, it's not a big thing. Respiratory rate is just important in someone who's breathless. If someone is breathless and really gasping for air and hyperventilating, then it's important to check the respiratory rate if you notice someone doing that. But if it's a cardiac case and you forget respiratory rate and he's not really demonstrating any breathing issues or breathlessness issues, not a big thing at all. Only thing is if someone is really hyperventilating and more than 24, if you count it as more than 24, then it's you have to then say, I'm going to monitor your respiratory rate throughout my treatment as well, because I saw it was more than 24. So we'll be careful. If it is more than 27, you say, I will stop it right now. Let's call the nurse because your respiratory rate is more than 27. So again, respiratory rate, you count it and then you say, oh, I counted it as this much. Is that right? So you confirm with the examiner, because your actor can't really act out hyperventilation. So you can then confirm with the examiner. So sometimes some scenarios they have given that where they would tell it's higher than what you counted, because your client will, your actor will have normal every time. Then look for the posture. How is he sitting? Especially important for postures with someone with COPD, they may be leaning forward, really uncomfortable. Someone with surgery, they will be holding the surgery side, leaning to the surgery side. And one of the I remember one of the scenario was where this client had a ICD drainage on the right and was in a lot of pain and was really lying on the ICD drainage, lying on top of the intercostal drainage and moaning in pain and saying, it's so painful. And then right away your posture is wrong there. You can, you have noticed the posture and you have to right away correct that person and make him comfortable, tell him that you cannot lie on the side of the ICD intercostal drainage because it will kink and it will stop. So they may put that type of scenario and try to look at your reaction or your management there.
Sorry, Samana, he was lying on what?
Oh, he was This was a female actor. She was lying on top of the intercostal drainage. So the intercostal drainage was on the right side, right lateral chest,
Oh, yeah.
and she was lying down right side, lying on top of that thing, that
Yeah.
pipe. So that's very dangerous, right? It could kink. You could bleed out. You could poke it further into the lungs, and she was doing that. So this is the presentation of the lady who falls from the hearse, has had a fall, and fractured her ribs and fractured her patella as well, because she has a Zimmer splint as well on the knee. So that lady, that young lady, was acting out like that in one of the candidates' presentation. Not all, different in different ones. Again, they will change pattern slightly, even though the same case will be there for your day. With the 3 exams throughout the day, it might be the same case, but they will change presentation slightly.
Yeah.
So then now let's move on to looking at head to toe. So I always like to do head to toe, like face, neck, thorax, hand, and legs, so that I don't miss out anything. So I look at the face for nasal flaring, cyanosis, blueness around the cheeks or the lips, puffiness around the cheeks again, looking at the accessory muscle as we looked at before, then looking at altered breathing pattern, as I said before, Hoover's sign, chest shape. Chest shape you may not see, so not really relevant for this simulation exam, and because the actors can't do that. And look for the post-op dressing. So when you look at the post-op dressing, if there is a dressing, please do not touch the dressing and just have a close look at it. Like if you know that there is a dressing on the side of the chest, ask the permission, lift the dress up, cloth up, and have a close look at it and say, am I seeing any oozing? Am I seeing any wet bandage here? So just remember to do that, but never try to take it off. Someone tried to take it off. That's not right. You cannot touch that area. If they say there is pain in that area or around that area, wear a pair of gloves, and then around the area you can palpate, but not maybe on the bandage itself. Do not push on the bandage, avoid that area, because there's safety again, you can't really push down on the bandage or dressing. Then you've got on the hands, looking for tremor, clubbing, nicotine stain. Again, nicotine stain you may not see, but you just say I'm looking if there is any nicotine stain. Am I seeing any clubbing? Am I seeing any edema on the hands? Am I seeing any tremor? So I did that. I kept going on with this symptom, saying, am I seeing? And they would then say, yes, there is tremor, or yes, there is clubbing. Again, at the legs, check for, do the quick DVT check right now there. Then check if there is any stockings. If it is a post-op client, then the person would be on stocking. Removing the stocking is important, just to check for the DVT, because you need to look for redness and warmth or any swelling. Don't really squeeze the calf right away, because that's again, sometimes when you squeeze the calf, if it is a DVT, there is a risk of dislodging the thrombosis. So please don't squeeze really hard, slightly palpate it. And then ask, is there any pain when I'm touching here, or is there any swelling or redness? And they like you to really, as we do with our patient, take the socks up. I would suggest, please don't take the entire thing off. If they have a TED stocking, take the entire thing off, because it's okay to take it off and go for a walk and all, or just take it off from the bottom part. So take it off of the ankle, check it there, and then bring it back down again. Then checking for pitting and non-pitting edema there. If there is edema, then you say, I'm checking now pitting. Is it pitting or is it non-pitting? Yeah, so these are some of the signs. I'm sure you all know, looking for cyanosis, clubbing, and nicotine stain here. This you will not see, but just they will prompt you. Then looking for pursed lip breathing, they will do this acting very well. Pursed lip breathing, they will do. I had my client was doing perfect pursed lip breathing and nasal flaring when he was doing it. So yeah, they will present you with that. But then again, with the mask, difficult to see that. So yeah, that you might have to ask again.
Sorry, Samana. In the exam now, the actor will be wearing a mask, and we are not allowed to ask them to take it off.
I think so, yes. And that depends on like what time or which month you are in and what's the rules and regulations during that time. Because sometimes, like I think currently to be in a small room, everyone has to wear masks. So he will wear mask. We can't ask him to take off the mask, I think. And that's what the rule is as per the, health the health department says. So when I give my exam, I couldn't ask him to take his mask off at all.
Right.
But-
So for me as well, I will wear a mask.
Yeah.
And how I will teach him, for example, the pursed lip,
Oh, yes,
or
it's very hard.
huffing, or coughing. All
It's
of
very
this.
hard. Yes, I thought just by explaining, I said make a O, and then I just had to just say everything by explaining through words. Couldn't really demonstrate it, so that's difficult right now. But if you really explain it well through your words, then they are happy because they also understand the limitations, and you also understand. I think no, I couldn't. No, for my exam, I couldn't take off the mask at all. But then for some others' exam, they were allowed to take it off briefly, like staying 1.5 meter away, but take it off briefly to show that, and then put it back on. So that depends on like what restrictions are there on the day of your exam. So yeah, really difficult. You have to use your words.
Thank you.
Yeah. All right. So alter chest shape, again, not really relevant, but you can ask, like if you have a COPD client, then just ask, am I seeing barrel chest shape? Not a big thing. If you miss this, you miss this. That's not a big thing to worry. Then you've got observation, looking at the symmetry of the chest movement, which again, you have to ask because you won't see it right away. Accessory muscle uses some, you may see it if the actor is doing it really properly. If not, you have to ask again. If there is any abnormal breathing pattern, like this, they have acted out really well. Most of the actors, I mean, as far as my feedback from different candidates, the depth of expiration is really low in that client who has a lot of pain and not really breathing properly because of pain. They were doing really shallow breathing in that point. So especially when you say like, I'm going to have a look at your breathing, and then they will start acting right away there. Then just so when you do this observation, keep talking, keep saying, I'm looking for your breathing, I'm looking at if you have any shallow breath, am I seeing any shallow breath? So then the examiner will prompt every time, give you the answer. Then a flail chest, again, you cannot see, but you can ask, am I seeing any flail chest signs? Am I seeing Hoover's sign? But please ask what's relevant to the condition. Like flail chest, you wouldn't see if it is just a COPD client or a cardiac client. You'll never see the flail chest. You ask if there is rib fracture only. Hoover's sign, you ask if there is chronic pulmonary condition. Otherwise, please don't ask. No point of asking that. So remember those conditions and correlating the signs. Then you move on to palpation. Here you ask for permission again because you're going to touch the client. Here, when you bring him to palpation, you have to, before you bring him to like this sitting position, you can do this sitting like this as shown in the slide here. Or you could do it just bringing him slightly upright on the bed itself, placing your hand on the lower chest at the anterior chest wall and checking for that chest expansion. You can choose to do any way. So usually it's easier to do it when the person is like sitting upright on the bed without bringing him here. So the limitations to inspiration could be seen, especially in rib fracture or pneumothorax or post-surgery. So just seeing that, again, you have to ask, am I seeing symmetry in this? Whereas, the reduced chest expansion, they are good at acting it out. And you will see that like my patient, he really acted it out well. I could see very reduced chest expansion right away. So I commented on that. Then auscultation, they really like to see the right auscultation points. Okay, they really like to see a very good auscultation point. So when you will auscultate, you will see that one of the examiner will get up and come really close to you, and like because the examiner is also has a body camera and is recording the auscultation point, and they will like to see these points here. So please practice auscultating at the right points. as here. I really don't know if you need to do 10 points. I just did 8 here and 6 here. I don't go for 10 points at the back, but they do like to see you do it in between the scapula. Some have done it over the scapula and did not get the right. So what happens is when you do auscultation, please also remember to wait for every breath. Complete one breath cycle on every auscultation point. So many times we are so nervous that, you will do like 1, 2, 3, 4, 5, 6, I'm done. But no, they won't give you the result. They will then say, nah, you couldn't hear anything. Or they will say, very low breath sounds. You could hear not, So please, full breath sounds in every breath cycle and every point, and ask for, after you finish the front, ask for the result. What am I hearing? Just ask, what am I hearing? What are my added sounds? Then at the back again, after all, you ask the same question. So then they will give you answers like these. They will say inspiration louder than expiration. They will say normal breath sounds at time. They may say like reduce breath sound, reduce over a certain area, reduce at that part. They will give you things like that. Reduce air entry or at certain point, or increase sound. So then. And then when you ask added sounds, they may give you wheeze or crackles. And never I have heard anyone give them a pleural rub thing, but usually the common added sounds they say is crackle and a wheeze. So if you hear a crackle, then you right away, there is secretions, and then okay, someone's coughing right now. So yeah, there is crackles, then right away that you have to work on airway clearance. So what I would do is after you have the breath sounds, tell to him, oh, I could hear you had some crackles. You also said you were coughing. So see, I think we can work on this goal. If you would like, we can work on, I can help you with removing the secretions. Sounds like your lungs really congested. So you're really slowly building towards goal again. Then cough strength is asking them to do a cough. And then seeing how it's their strength. Do they do a good like that, or they do sometimes they will just something like that. So then that you are not coughing well. So you just tell them, I could hear that you are not coughing well. I could see that you are coughing well. So something like that, and you have another outcome measure right away. So your outcome measures here, your outcome measures here. And then you also have an outcome measure with the chest expansion. They really show good improvement. They're actors. If you give a good lung expansion technique, if you take them for a good walk, they will show you good expansion right away at the end. Then checking for the transfers and mobility. Check for the strength before you get them up. Check for the upper limb strength if they are using walking aids like rollator frame or walking stick, because they need to hold that. A lower limb check for the bridging and everything, checking the usual, like how you would check for neuro or musculoskeletal condition, hip flexors extensions, knee flexion extensions. Just that avoid bending the knee or the straight leg raise in abdominal surgery if they are that, because that is again safety. Just slightly bend it and say, are you comfortable? Don't bend it fully so that you are not pushing down on the on the suture site and causing more pain. So please be mindful of that. And then you check for the transfers and mobility. So here you would have already asked earlier if this person is one physical assist, one standby assist, or 2 person. So if this person is 2, this is the point you have to then ask for help from the examiner. I'm going to ask one of you to please be my assistant, and please could you assist me? So right away, please remember, before you get someone up, if the person is to assist, there should be another person there. Then check for rolling on the side, lying to sitting to standing, and walking. So you check all of that. With that, you are checking the 4.2 criteria here, which is the 4.2 criteria is actually the safety criteria, that is preparing the equipment and environment before you move the client or before you start assessing the client. So when in cardiac, one of the difficulties is there are lots of lines. If your client is a post-op, especially, there will be like lines, ICD line or a catheter line. There will be IV. So try to get all of that to one side or to the front of the person. I use the technique of bringing everything to the front. That always is easier for me. And remember, then just make sure nothing is tugging at him. If the person stands up and starts walking, then you can even hang them on the walker if he's using the walker. If not, then you and your assistant hand will hold it. Yep. So that remember that because they will be checking whether you are maintaining the safety. Then that then ends our objective assessment part. Then if after objective assessment, please, you have to renegotiate your short-term goal right away, because then you will have identified the signs. Like if earlier he had said, oh yes, cough is there, and then you have auscultated and you found there's crackles, then you can say yes, there is cough, or so we need to work on that. Or let's say he didn't mention anything about difficulty in deep breathing, right? He said, I'm fine with breathing. But when you did the chest expansion check with your hands, you notice that there is really no movement at all. There is no good breath sounds on your auscultation. Then you have to say, I noticed this and this. Would you like, how about we work on this as well, improving the lung expansion? Again, asking for permission from them, but then helping them to form their short-term goals. So identifying the outcome measure and the short-term goal prioritization happens in the objective assessment part. Right. And then rationalizing and prioritizing a treatment. Although we wouldn't normally do this with every client in normal practice, but here in exam, they really like to hear you rationalize and prioritize your treatment very loudly. So please do that. You have to then tell, okay, first I'm going to do this with you because this is more important. Then I'll do this after. Then this, just tell everything, how you are going to do and why you're doing this first and this next and this last. So you are getting your ticks on 3.5 and 2.4 criteria. And again, before starting the treatment, ask the consent. Can we start? Can we start with some breathlessness management technique? Then this again, big tick for 4.1, taking the consent. Yeah. So that's the part until our treatment planning. Right. So how is it going so far for everyone?
Yeah, thank you. I have a few questions.
Mm-hmm.
Number one question is while you were talking about auscultation and breath sounds, I did hear that sometimes in the exams, one of the assessors might have an iPad. As soon as you're done, they will play the sound and they'll ask you to identify it. Is that correct?
True. I have heard it from 2 candidates, only 2 so far. Yep, they can do that. So good to just listen to a few, but they won't give you that tough. I think it's just crackles that they are giving. Crackles and reduced breath sounds is what they are giving. Maybe wheezes. Wheezes is also really easy to identify. I wouldn't worry about others. Yeah.
Okay. And then the second question is when it comes to transfer, because that's where most of the candidates have a safety issue. Can you throw more light on that? Because I've been having an issue sometimes we've been having this a little bit of disagreement with my practice partner. So I was of the opinion that if a patient has got too many attachments, like normally you have to first of all, once you come in, try to identify all the attachments and ask any questions if you're not clear. But then during transfer, like you said, you move it to one side. You did mention about moving it in front. Can you throw more light on that? And then, sorry.
Can I ask you all to rejoin through the same link again, part 2 link, because we are going to be timed out again. I'm so sorry about that.
That's okay.
Can I ask you all to rejoin? I will be. Yes, I will leave
the same.
Yes, same one, part 2.
All right. So you finalize that, and then we.
Yes, part 2. Please join with part 2.
Right.
Let's leave this, end this, and rejoin through the same